Bismillahirrahmanirrahim. This is Dr. Usman Akhtar and welcome to my YouTube channel. As we were discussing about the cardiomyopathy, the second type is hypertrophic cardiomyopathy. It is a massive hypertrophy of the left ventricle, especially the interventricular septum just below the aortic valve. If we look at the diagram, this is a myocardium of a left ventricle. This is, I just drawn the left side of the heart. This is the left atrium and this is the left ventricle. So if we look at the myocardium of the left ventricle, it is so much hypertrophied that the lumen of the left ventricle become very less. So whenever the blood come from the left atrium, the blood filling of the left ventricle become very reduced. So in hypertrophic cardiomyopathy, the main function is the heart, or we should say the left ventricle cannot fill because of the decreased lumen, and it is because of the increased size of the myocardium. So in hypertrophic cardiomyopathy, the main defect is primarily the diastolic dysfunction, or we should say a diastolic failure. If we look into the causes, some of the hypertrophic cardiomyopathy cases are idiopathic. We don't know the cause. But the most important, about 70 to 80% cases are hereditary. In hereditary, mainly the problem lies in the sarcoplasm of the myocardium. The gene become mutant, which is responsible for the production of the beta myosin. So main problem lies in the sarcoplasm of the myocardium, which lead to the increased size of the myocardium. So if we look at to the clinical feature, there will be palpitation. Palpitation basically we can define as if one can feel his own heartbeat is called palpitation. There will be increased cardiac output. Basically, if we look at here, first of all, there is diastolic dysfunction. The heart cannot relax properly, so the left ventricle can fill up and that blood can be pumped outside the left ventricle. First of all, the diastolic dysfunction. But another one, the reason for the decreased cardiac output. Whenever even the reduced amount of blood come to the left ventricle here, so whenever the myocardium contracts, this hypertrophic part, which is just below the aortic valve, this becomes squeezed and this portion come into the in front of the aortic valve. So the blood came out from the left ventricle, came into the aorta in very reduced form. It is very minimum. So the stroke volume becomes so much decreased. So there will be decreased cardiac output, and because of the decreased cardiac output, whenever the patient with the hypertrophic cardiomyopathy, when they go for some exercise, or I should say for severe exercise, so there will be decreased cardiac output, which will lead to the decreased supply to the brain, which will lead to the syncope or syncope. In some patient, there will be sudden cardiac death, especially in athletes. And athletes, like so many athletes we have seen, especially in football or rugby, where the person go for a severe exercise. So there will be, because of the decreased stroke volume, or in turn the decreased cardiac output, the person can go into the first angina, then ischemic, and then can go for the MI even. So sudden cardiac death is most common in this type of the cardiomyopathy. In hypertrophic cardiomyopathy, there will be S4 heart sound. What is S4 heart sound? So whenever this left atrium contract vigorously against the stiff ventricle, this contraction of the left ventricle produce a sound which we call S4 heart sound. And if we take a biopsy from the myocardium, the biopsy shows myofibril with a disarray. So the myofibril, which was arranged and a normal, which is arranged in a very specific way in a normal people. But here because of the beta myosin chain defect, especially heavy chain defect, there will be disarrangement of the myofibril. If we go for the diagnosis is if we look at the clinical symptom, and then we can go for the echocardiogram. Still, echocardiogram is the investigation of choice to diagnose hypertrophic cardiomyopathy. If we look at the treatment, we can give the beta blocker. So the beta blocker can reduce the workload on the heart. Calcium channel blocker, same mechanism. Avoid ionotropic agent. This is very important, like digitalis or digoxin. If you give the ionotropic agent in such a patient, even it increase the heart contractility, but if even the myocardium of the left ventricle, if it contracts, it still blocks the way for the aortic valve. So it even still it will decrease the stroke volume. Use diuretic with caution, because the stroke volume is already decreased. So we do not want that our blood volume become less, and we don't want the cardiac output stroke volume become decreased further. And the treatment of choice is left ventricular myotomy. So in left ventricular myomectomy, we remove some part of the myocardium. So the lumen of the left ventricle increase, and the filling defect is can be corrected in this way.